Hello, Insta family. How are you? It's Dr. T here. Tuesday night, back after a refreshing week in Rottnest. Had a fab time, first week of the school holidays. I can't decide whether I'm happy about school holidays or not. I'm a little bit late tonight. I've realised I haven't really brushed my hair. No, I don't have any makeup on. And yeah. So that's the school holiday challenge. Except the one great thing is I don't have to make lunch boxes. I've got to be happy about that. I suppose really I should just be grateful that I've got school holidays, right? Yep. I know a lot of you out there would be saying, Tamara, school holidays means you've got kids, right? So I should be a bit grateful. And I am. They teach me something new every single day. So how are you guys? I hope you guys are doing okay in this run up to Christmas. For some people, it's a fabulous time. For others, it's a really challenging time. So I just want to acknowledge all of you out there on your journeys around this somewhat challenging time of year. And just, I hear you, sisters. I hear you. So just know that, you know, part of this journey in life is the learning. And you develop incredible wisdom that perhaps some others don't get that opportunity to learn. So as hard as it is at this time of year for some of you, just know that there is incredible learning and wisdom that you're gaining as an individual that I know will put you in great stead for other things coming at you in your life moving forward. So I'm back. Second last Q&A for the year, I reckon. I reckon we'll do another one next Tuesday night. What'll that be, about the 20th? And then we have a little Christmas break. And then we'll come back fresh and fancy-free in 2023 to get started again. Now, I did have to just jump on. There were a few questions, which is fabulous. But if you do have any other questions, please drop them into the comments here. Remember my motto, keep it short and sweet. Don't need a whole life story. Make it as generic as possible. You'll be getting a generic answer. Because no doubt there is somebody else out there that is just dying to ask the same question you have. So we want to make sure that the answers are applicable to as many different people as possible. And I'm not going to be here all night. I just don't have the brain capacity today. Look, before I start, actually, I want to address something. I have had quite a few patients coming to see me. Thank you for choosing to come and see me. Who, as women in a relationship, are insisting on coming to the appointment by themselves to sort out their fertility. What I want to remind people is that fertility is a couple thing. You know, up to 15%, even if your partner has had a child before, it might not be with you, but even if they've had a pregnancy or a child before, it doesn't mean that the problem doesn't lie with them. So sometimes I know how difficult it is to get partners to come along. But here's the other great thing about a bloke coming along. I'm just talking about male and female partnerships. Obviously, at this point in time, there are lots of other partnerships, and I do acknowledge that. But I'm just talking about a male and female partnership at the moment. Sometimes blokes are not very good at exploring their own health and well-being. In fact, generally speaking, less blokes go to a GP than women do. And if you hear me on that one, girls, just give me some love because it's a common thing. Sometimes coming to a fertility specialist can be an opportunity for a bloke to get a bit of a well-man check. You know, to have a chat with a medical practitioner about smoking, about drinking, about exercise, about weight loss, about toxin exposure, things that sometimes can be a bit of a nag from their partner, but when they hear it from a doctor, it can be of great value to you guys in supporting them, in supporting your fertility journey. So bringing your bloke along to a fertility appointment is doubly valuable. It's valuable because I can figure out if there is actually something about them that contributes to the infertility issue. because in 15% of cases it is the bloke. But equally, it gives us an opportunity to do a well-man check and just make sure that there is nothing that is needing to be addressed in their general health and well-being that might have an impact on fertility as well. So please, if you can, make sure that your bloke comes along to the fertility appointment with you. Don't assume the problem all lies with you. And in truth, even if you do have a really obvious female problem like you don't ovulate, or you don't ovulate regularly, doesn't matter. Still got to check out the bloke, because there's no point me doing treatment on you without ensuring that everything with him is a-okay. But not only that, they get to experience what it is that you're going to have to go through. And it's so important that people around you, who are your support network, including your partner, understand what it is that you and them are going to need to go through. Because it's a couple journey, right? In most cases. So I'm just going to get off my soapbox. I've been on my soapbox now for a couple of minutes, but that's really, really important. So when my beautiful admin and secretarial staff insist that you bring along your partner, there is method to my madness, right? There is a reason why I'm wanting your partner to come. So please don't put up too much of a fight. It's a bit of a challenge for my admin staff. Don't make it doubly hard for them. All right, I'm hopping off my soapbox. Now, I did see some little posts. Kayla Jameson. Could little lack of cervical mucus be an issue with time to conception? Is it okay? Tips to improve. Cervical mucus. Well, it's a very subjective assessment, to be perfectly honest. Some people think that a lot, others might think of as not very much. So assessing cervical mucus is notoriously inaccurate, let me just say, putting it out there. It's not so much an impact factor as a result potentially of some sort of disordered ovulation. So cervical mucus changes is very much indicated by the presence or absence of both estrogen and or progesterone. So lack of cervical mucus can maybe indicate to us that, maybe you're not actually ovulating. Maybe you're not actually producing estrogen to create the cervical mucus changes. So it's not that it's something that you need to necessarily improve, but rather it might be reflecting an underlying issue. Kayla Jameson, hopefully that's helpful. Carolina, Carolina, I did get your question. Iron levels. I absolutely would encourage you to have adequate iron levels entering into a pregnancy. So is it going to do any harm to a transfer? No way, absolutely not. Is being iron deficient entering a pregnancy a problem? Yeah, it is, because you are going to become more relatively iron deficient as the pregnancy goes on, contributes to tiredness, contributes to anemia. So hell yeah, go and sort out your iron levels before you actually conceive. An iron infusion is different to an intramuscular injection, is different to taking an oral iron supplement. Generally speaking, we would encourage you to take an iron supplement as first line if that's then been unsuccessful in iron infusion. Iron intramuscular injections tend to stain the skin. There is also a 1% risk of an anaphylactic reaction or a fever when having an iron infusion. So just understand that it's not completely without risk. And if you can obtain reasonable iron levels with daily or second daily oral iron supplementation, then that should be adequate. Hopefully that's helpful. SASOR, what is the usual average day for transfer in a frozen embryo transfer cycle? Well, depends on the age of the embryo, but you want to make sure there's progesterone. So generally speaking, progesterone starts to come in a stimulated or natural frozen embryo transfer cycle about 2 days after an LH surge, which is about 12 to 24 hours after you have had ovulation. Some people get early luteinization or early progesterone production. And you want around about 4 to 5 days of progesterone presence before considering an embryo transfer, because you're most likely to be transferring a day 5 embryo. So you want that to be in sync with the age of the embryo. So your window of implantation is anywhere between day 6 and day 10 post ovulation, day 7 to 11 post LH surge. So yeah, it's all about the number of days of presence of progesterone. And that is either counted from the ovulation, it's counted from the day you start your progesterone if you're doing a hormone replacement cycle. But yeah, and it all depends on the age of the embryo that you're actually transferring. So obviously if it's a day 3 embryo, you're going to be transferring it earlier in the progesterone exposure. Good question. Okay, I know there's another one here. Caroline has asked another question. Speaking of guys, does I'm guessing that means sperm extraction, improve sperm quality if someone has low sperm due to CF carrier gene? Okay, so the first thing I want to say is you must go and get carrier status assessed yourself, Carolina, because if you're also a carrier, there's a 25% chance you could have a child born with CF. It's also not completely negligible even if you're not a carrier, because there could be a de novo or spontaneous mutation. So I think it's important that you guys have had some counselling around that. Low sperm count due to CF carrier gene status. So if he has cystic fibrosis, then it can affect low sperm due to partial obstruction of the vas deferens. Does sperm extraction improve the quality? No, it just increases your numbers, because it depends where you're accessing it from. So if you're accessing it from the epididymis, it is mature sperm. If you're accessing it from the testis, it is immature sperm, must be used with ICSI, and also will have less DNA fragmentation damage because it's been somewhat protected. So sperm quality is a difficult thing to assess. How do we assess sperm quality? Very hard to assess sperm quality, but it's far less likely to have oxidative damage if it's coming from the testis as opposed to the epididymis, but it's also going to be less mature. So you have to do ICSI with testicular sperm. But if he's got sperm that he's ejaculating, why would you not use that? Good question for your fertility specialist. Okay, no more questions here. Lovely to see all you guys on. I do have some questions that came through on DM. Thank you for sending those through. The iron question has been asked. Someone also asked me about, it's probably a little bit of a personalised question, but they've got PCOS and they need to work on improving ovulation and weight and diet and lifestyle. Partner also has high DNA fragmentation. Which thing to tackle first? At the same time, do both is my suggestion. So a man with a high DNA fragmentation, there's lots of different reasons why this could be so. It could be that they don't have very high testosterone levels. It could be that they have a varicocele, which you can only see on an ultrasound. It could be that they've got some sort of toxin exposure, smoking, alcohol, herbicides, pesticides, occupational chemicals. So it's really important that your fertility specialist explores all of those things to see if there's some trigger that can be managed. And although there is little evidence, I would always recommend including a multivitamin that includes antioxidants. And also look at frequent ejaculation, because if sperm is sitting in the epididymis for a long period of time, it's going to get hit by all these free radicals and that increases DNA fragmentation. So frequent ejaculation is a way of bringing down DFI. So the PCOS, the ovulatory stuff, definitely gets stuck into lifestyle, weight management, metformin, decreasing sugars, looking at reducing hyperinsulinemia, all of those sorts of things. So a bit of dual factor fertility, both of you should get to work. Give it a good 3 months. You never know, you might spontaneously fall pregnant. Sassor has another question, another embryo transfer question. How important is the doctor's skill in transferring the embryo into the uterus for success? Yeah, great question. Somewhat controversial, but it is really important that the technique is good. There are a few things that can affect pregnancy at transfer: the endometrial preparation and the time of transfer, the embryology. So, if it's a thawed out embryo, if it's, been well cared for in the lab, and of course the technique of the doctor. And there is evidence around certain things at transfer, things like the instruments to use, the technique to use, the placement of the embryo. Certainly using ultrasound is fairly conclusively proven with a full bladder to improve outcomes. So yeah, doctor's skill level does contribute. And if you've got a good fertility centre, they will be monitoring the performance of their doctors on embryo transfers. So yeah, it's kind of important. I certainly like to know month to month what my personal success rates are, because as someone who's always open to improving, always testing and measuring and calculating and, modifying things to improve it, I think is the mark of a really good doctor. So great question. It certainly does impact. As far as what proportion, difficult to say. Okay, somebody else asked the question about window of implantation and recurrent implantation failure. This I could spend a whole half an hour talking about. But the first thing to identify is what is the definition of recurrent implantation failure? That's the first thing, because there's lots of different definitions. So I guess as an overall, it is the transfer in an IVF cycle, the transfer of at least 3 good quality embryos without a pregnancy. So then the question is, how do you judge an embryo's quality? And that's really where the controversy lies. Are we suggesting that good quality is determined by the chromosomal status? So if it is it chromosomally normal or not? Is it determined by morphology, how the embryologist has assessed it? What grading system have they used? So that is where one of the controversies is. But however, if we say that we have, using some technique, transferred at least 3 good quality embryos and someone has not conceived, there is an impetus for us to start looking for a reason why. So is it the endometrium? And in 2/3 of the cases, it often is. Or is it an embryo issue? It's much easier for us to go and assess embryo quality because we can do genetic testing on them. And so often that is our first call, is to do pre-implantation genetic testing for aneuploidy status of embryos, particularly on someone who produces 5 or more embryos. And if I can show that the majority of those embryos are actually chromosomally normal, I'm then going to focus my attention on the endometrium. And as many of my patients know, I often say we know more about outer space in the universe than we do about the endometrium. It is a largely poorly explained organ system. And one of the more recent things that have been examined about the endometrium is whether or not that window of implantation, so I talked about it before, day 6 to day 10 post-ovulation, whether or not that window of implantation in some people, due to lots of different things, endometriosis, disordered ovulation, whether that is actually for that individual truly day 6 to 10, or maybe it's day 7 to 11, or maybe it's day 5 to 9. So perhaps there are a population of people who do have this displaced endometrial window, and how do we assess it? So there's lots of tests on the market, endometrial receptivity assays, that can utilize things like genomics, like metabolomics, like proteomics, to assess that window and the optimal time to individualize an embryo transfer. Is the data robust? Not really. I think the data is most robust on these people, maybe if they've had 6, 7, 8 embryos transferred without success. So that's when you're starting to think, oh, there's something really pathological here. This is not just a numbers game. This is not a doctor transfer issue. This is not an embryology issue. This is maybe something about the pathology of this endometrium. So it's kind of often the last port of call. Often we go and look for the endometriosis. Often we go and do the anatomical scanning looking for a septum, polyp, fibroid. Often we go and reassess the endocrinology to make sure there's not sort of thyroid issues or insulin resistance. Often we go and assess the semen analysis and DFI to look for a male impact on embryo quality. So it's complex. That's the simple answer to the question. It's truly complex, and often you end up dealing with the pointy end, the much smaller populations of people, because we've exhausted everything else first. But it is definitely a thing, and it's one of those watch this space areas of research. So yeah, have a chat with your specialist about it. Oh, the questions are just rolling in. So are the love hearts. Thanks, guys. Feeling very loved this evening. Now, where's the next question? Does going to low stim compared to high stim always mean you'll have less follicles? Yeah, because you're closing the window of stimulation. You kind of close it. So the way I talk to patients about it is that when you do controlled ovarian hyperstimulation, you're kind of opening the gate to allow more follicles to be receptive to stimulation. But there is a school of thought, particularly in poor responders, so older women who naturally have expected lower numbers of follicles, that you probably don't need to open the gate that much because there's just no more follicles to recruit. And so just dropping the dosage down is actually a little bit more physiological. You might still only get 1 or 2 eggs, but you're not having to pound them with really high doses of drugs. And these drugs aren't particularly cheap either. So generally speaking, you will always recruit less follicles with a lower dose, but that may actually be your intention, right? You know, you may be trying to avoid ovarian hyperstimulation syndrome, or in people who just naturally don't have a good ovarian reserve, you're just wanting to recruit the 1 or 2 that they were going to recruit anyway. Hope that answers the question. Santinus Treasures. I've probably got about a couple more minutes in me, guys. Can ovarian hyperstimulation affect the egg quality and impact fertilization and embryo development rates? Can ovarian hyperstimulation? Well, given that a pregnancy rate after an IVF cycle is significantly higher than a natural cycle where someone just produces 1 egg, and the children born from IVF are pretty much the same as children conceived and born spontaneously, one would think, therefore, that controlled ovarian hyperstimulation probably doesn't negatively affect egg quality, nor does it negatively impact on fertilization, nor does it impact on embryo development rates. So just, I suppose, by a process of elimination, I would say, well, it doesn't affect it negatively, but certainly you're going to get more eggs. Putting the sperm right round the egg is going to improve fertilization rates, and you're going to develop more embryos through to day 5 in a nice standardized culture environment, which therefore gives you a much greater chance of a cumulative pregnancy rate. And even if you're transferring a day 5 embryo, you're going to have a much better chance of a pregnancy than if you tried to spontaneously conceive. Hope that answers the question. Okay. Carolina, oh, bless you. Thank you. Pre-genetic testing, yay or nay? Pre-implantation genetic testing. Look, I'm a little bit of a fan when people are looking for an explanation as to why they're not conceiving with presumably morphologically good-looking embryos. Why I say 5. Look, if you sat around a table, and I have done this, if you sat around a table of several gynecologists and said, how many embryos would you need in order to send them off for pre-implantation genetic testing? The reason that I kind of have this arbitrary threshold of 5 is this. it's not really about the cost or anything like that. What it is for me is if all of your 5 embryos came back and they were all deemed chromosomally abnormal, I'm going to tell you to stop treatment. That's what the benefit to me is. I'm not going to continue to drag you through cycle after cycle where you produce 1 or 2 embryos. I'm going to give you information that is truly valuable to help you make a pragmatic and educated decision moving forward. That's me. If you were to send 1 or 2 embryos away for testing and they both came back abnormal, I can't tell you not to go again because proportions kind of say, statistics kind of say, well, there's a fair chance if you're above 35 and you're only getting 2 embryos tested that they're both going to be chromosomally abnormal. It's not really valuable for you. The value in a young woman going for pre-implantation genetic testing who is going to produce a lot of embryos is that deselection. You know, instead of having 8 embryos to transfer and then transfer and then transfer and then transfer, she might only have 3 or 4 of those embryos that are normal and the rest are abnormal. So she's just saved herself about 4 transfers. That's, 4+ months worth of treatment. That's time. So in a younger woman who's going to produce lots of embryos, I think it's really valuable. In an older woman, if they're getting a decent number of embryos, I think what it is for me is about being pragmatic about whether or not it's a good idea to keep going with treatment or looking at other alternatives. And you probably know what they are. All right. Whew. I think I've done all right for a Tuesday night, don't you think? It's been a hefty day for me. I've done everything from pediatric gynecology through to surgery, through to IVF, through to ovulation induction. I've wiped bottoms. I've put children in baths. I didn't make dinner. I've got to give my husband credit for that. He did that tonight. So now I think I'm just going to put my feet up for the night, signed off, and I'll see you guys next Tuesday. I've got some good things coming. Good things coming for 2023. I'm super excited. So make sure you hang around. There's the wiggle move. Have a good rest of your week. See ya.